Hi, everyone. My name is Irina Skylar-Scott. I am a clinical assistant professor at Stanford. Today's episode is on anti-amyloid treatments for Alzheimer's disease. We're all excited about this new era of treatments for AD, and we're hoping that this is just the beginning. So these are my disclosures, and here are some questions I'm hoping to answer today. In particular, I want to talk about whether lecanemab is in fact effective and safe. Is donanemab effective and safe? And then I'd like to compare the two. So we'll start with lecanemab. So lecanemab, which is also known as Bantu 401, actually acts on A beta protofibrils, which are thought to be the most neurotoxic formulation of beta amyloid in addition to oligomers, rather than the end-stage amyloid plaques. It was developed by Eisai and Biogen and received accelerated approval followed by traditional approval in July of 2023. And this is the key slide, the most important slide, looking at efficacy of lecanemab. Lecanemab is in yellow, placebo is in blue, and the primary outcome measure was something called the CDR sum of boxes, which is an 18-point measure. You had just under 900 people in each group, and the CDR sum of boxes looks at a range of different outcomes, including memory, orientation, as well as functional outcomes like community affairs and home and hobbies. And it's really a self-report questionnaire. And on this measure, there was a difference of 0.5 on an 18-point scale. So about half a point between lecanemab and placebo between the two. In order to determine if it's truly disease modifying, what you want to see between those two lines is that they are increasingly separating over time. And I do believe that we can see that on this graph. And so many people wondered whether a half a point difference is truly meaningful. So I just wanted to point out this study that looked at clinical meaningfulness, which is based on a clinician's assessment of meaningful decline in memory and other domains. And what they identified is that depending on the level of severity, the clinically meaningful change in the CDR sum of boxes varied. But at the level of MCI and mild dementia due to AD, which were the participants in the lecanemab Clarity AD study, it's between 1 and 1.5 points that's thought to be clinically meaningful. However, the minimum change threshold, at which over 70% of visits were classified as clinically meaningful, that change was 0.5. So we're just getting to that minimum threshold with this drug. What is clear and uncontroversial is that lecanemab is very good at clearing amyloid from the brain. So if you look at that graph in the upper left, you can see that there's a wide separation between placebo and lecanemab. And in fact, 2/3 of the treatment group went from amyloid PET positive to amyloid PET negative, which was defined as a Centiloid value below 25. And so here are a few pearls on what I explain to my patients when they're considering lecanemab or donanemab. So this medicine doesn't stop AD, it doesn't reverse it or cure it, it just slows progression. And it really just modestly slows progression. I also mentioned that the rate of slowing is about 30%. And the factoid that is most clinically meaningful to patients and families is that this drug results in a 6-month delay in symptom progression over 18 months of treatment. So that is really what I found to be most helpful in explaining the efficacy of this drug. And in addition, it is clinically meaningful that it can slow the rate of transition to later stages of disease. And so patients and families always want to know about the time commitment. It's about 60 minutes every 2 weeks, certainly for the first 18 months. And then thereafter, the company is recommending that patients get monthly infusions. It's expensive, and patients at this point in time are going to be paying over $5,000, even if most of the drug is covered by insurance. And there are many websites with additional information. This is our website that you're welcome to direct patients to for Q&A. Frequently asked questions. Other key pearls about lecanemab: it shouldn't be prescribed for patients on anticoagulation based on the appropriate use criteria that were published by Jeff Cummings and colleagues. In the original clinical trial, there were patients who were anticoagulated, but based on the potential side effects, including ARIA that I'll talk about in a bit, according to the AUR, it would be too dangerous to prescribe. Additionally, patients on lecanemab shouldn't be treated with acute thrombolytics like TPA or TNK. Thrombectomy is okay and safe, but the risk of bleeding is just too high. But antiplatelets are allowed. And I was at the conference where this AUR was first revealed, and the panel indicated, these are a strict criteria for now, and that may change over time as we get more of a comfort level with some of these drugs. But, I think at this moment in time, we'd rather be safe than sorry. And so in terms of who's appropriate for lecanemab, there are a number of strict criteria. So in the original phase 3 Clarity AD trial, you had to have MCI or mild dementia and objective impairment and episodic memory. Now you do still need to have MCI or mild dementia. So patients with moderate or severe dementia aren't eligible, but you can have an atypical form of AD like posterior cortical atrophy or frontal AD or leukopenic variant primary progressive aphasia, where memory isn't the earliest and most prominent symptom. You need to have a positive biomarker, and similarly, in the clinical setting, you either need to have a positive amyloid PET scan or CSF studies that are indicative of AD. Fortunately now, Medicare covers amyloid PET scans, so that has made it much easier to get amyloid PET scans for our patients. In the original study, it had to be 50 to 90. In the appropriate use criteria, they indicate outside of these ranges, physicians should use their judgment. The MMSE score is similar to that of the original study, so 22 to 30 or something equivalent on a MoCA or SLUMS. So that would be a MoCA that's approximately 16 or above. BMI, physicians can use their judgment, so that can be a little less strict than the original study. In the original study, you had to be on a stable dose of a cholinesterase inhibitor or memantine. In the real world, patients can be on these drugs, but they shouldn't have used any other drugs in this class. And you had to be stable with other drugs. And for now, we just want standard of care for medical illnesses. That you do need a care partner or family member who can go with patients to these infusions, particularly due to the risk of infusion reaction. So it's important that somebody is committed to going with the patient. And the AUR recommends at least a discussion with patient and family about the risks and benefits of these drugs. At our center, we do have an informed consent that we have patients and sometimes a family member, if the patient is assenting, sign to state that they're aware of all these risks and benefits. It is mandatory to do some sort of questionnaire that looks at function. So the CDR is appropriate, or you can use the functional activities questionnaire, which is shown here. And then you have to enroll the patient in a registry. So you can use the Medicare registry or the ALZNet registry, or there are other registries out there. But that is a mandatory requirement for these therapies. So there are patients who are excluded from lecanemab. And so if they have conditions that may contribute to their cognitive impairment other than AD, including other neurodegenerative conditions, they're not appropriate for this therapy because we don't yet know how these therapies would affect them. Additionally, if on their MRI scan they have any of these findings, including more than 4 microhemorrhages or more than 2 lacunar infarcts, according to the appropriate use criteria, they wouldn't be appropriate. Now, again, these are very strict criteria. I think clinicians who are comfortable with these therapies can use their judgment because, of course, some of these findings can be quite common. But certainly as a field, we've all decided that we want to be safe and strict for now, as I've said. A stroke or TIA within the last 12 months is exclusionary, and any history of seizures in the lifetime of the patient is also exclusionary. Okay, so another slide on exclusions, but we're nearly there. So if you feel that mental illness would interfere with their comprehension or ability to comply with the treatments, they might not be appropriate for therapy. And any history of any immunologic illness is also exclusionary because we really don't know how these therapies would affect these patients. And similarly, if they're currently on systemic immunosuppression, they may not be appropriate. Bleeding disorder, again, because of the risk of ARIA that we'll talk about shortly. And we've talked about anticoagulants and TPA. And finally, this is sort of a catch-all, but if they have unstable medical conditions, then they may not be appropriate for these therapies with many potential side effects. And so I promised you I'd talk about ARIA. So ARIA stands for amyloid-related imaging abnormalities, and there's ARIA-E, which refers to edema and infusion, and ARIA-H, which refers to hemorrhage and hemosiderin. And you can see ARIA-E in three of the panels at the top left and the two bottom panels. And this is mainly to show you that it can be quite obvious, as shown in the upper left, but you can see more subtle signs of ARIA-E as shown in the bottom right as well. And then ARIA-H can take the form of microhemorrhages, as shown in the top right, but can also take the form of superficial siderosis or macrohemorrhage as well. And so in the original Clarity AD study, about a fifth of patients had ARIA-E or H, but the vast majority were asymptomatic. And so, out of 113 who had ARIA-E, about 25 had symptoms. Out of 155 participants who had ARIA-H, about 6 had symptomatic ARIA-H. The risk of getting ARIA varies by ApoE status, whether they have 1 or 2 copies of the E4 allele. And so we get ApoE testing on all patients that we're screening for these drugs so that we can inform them of their risk. And the same is true of ARIA-H. And so potential symptoms of ARIA are listed here. They can be relatively benign, like a light headache or some blurry vision, but they can also be serious, and they can be life-threatening. And there have been patients who passed away on Lecanemab, so this is in part why we want to be cautious with patients who are on anticoagulation and in patients receiving TPA, because those are the patients who are at higher risk for fatalities. So this is the screening schedule for MRIs to look for ARIA in patients who are on these therapies once they get started on therapy. In general, ARIA tends to happen at the beginning, and in fact, over 70% of ARIA-E was detected on either the first or second screening MRI. And usually ARIA-E tends to resolve. ARIA-H, the microhemorrhages tend to stay, but any symptoms from them also tend to resolve. So this is the stopping criteria if you do identify ARIA. The key branch point is to determine if the patient is symptomatic or asymptomatic. And if they're asymptomatic and they have mild ARIA-E or ARIA-H, you can talk with them about the pros and cons. But if you determine together that they'd like to proceed, you can continue with treatment and just do monthly MRIs until the ARIA resolves or stabilizes. Another side effect that I wanted to point out is infusion-related reactions. So in the case of Lecanemab, about a quarter of participants had reactions related to infusions, and that could be elevated temperature, changes in blood pressure. So you want to be ready for those potential reactions as well. So let's switch gears and talk a little bit about Donanemab. So in this study, a few things to point out. The screening criteria was a little different. In order to screen into the study, you had to have evidence of both amyloid and tau pathology rather than just amyloid pathology in the Lecanemab study. There were just under 900 participants in each arm. And instead of every 2 weeks, participants got Donanemab every 4 weeks. So that is another key difference. They used a different primary endpoint, the Integrated Alzheimer's Disease Rating Scale, which has a score ranging from 0 to 144, with lower scores indicating greater impairment. And they were followed for 76 weeks. And ultimately, there was a difference of about 3 points on this IADRS scale. And those in the low medium tau group, in other words, those who had less tau, benefited more. And increasingly, the literature has shown that the earlier you are, whether it's clinical severity or tau burden, the more likely you are to benefit from these therapies. And so again, the question arises, this is statistically significant, but is it clinically meaningful? And so some studies have indicated that maybe 5 points would be clinically meaningful for MCI and 9 points for AD, and we didn't really reach that threshold here. Donanemab acts on the amyloid plaques in contrast to Lecanemab, which acts on those protofibrils. And there's some off-target binding for some of these therapies as well. So a few key differences with the Donanemab study. The Trailblazer-ALZ 2 study, there was stopping criteria. So if the amyloid levels fell below a certain threshold, then you could switch from donanemab to placebo. And the same is true in the clinical setting. The MMSE scores were a little different, 22 to 28 instead of 22 to 30. And so, again, this is the most important slide with donanemab when looking at efficacy, showing the difference between donanemab in yellow and placebo in blue. You have the low medium tau population on the left and the combined tau, everybody on the right. And what you want to ask yourself is, do you feel as though these lines are separating over time, indicating that this is in fact a disease-modifying treatment where that clears amyloid? And so with the low medium tau group, you had about a 35% slowing of clinical progression. With the total group, it was about 22%. So it's a little difficult to compare apples to apples between these two studies because their primary endpoints were different and their selection criteria were different. But the CDR sum of boxes was a secondary endpoint for donanemab. And so if you want to try and squint and compare the two directly, rather than a 0.5 point difference, there was a 0.67 point difference for low medium tau and 0.7 for the combined population. So, take that with a little bit of a grain of salt. So, similar to lecanemab with the donanemab study, patients using this global CDR stayed at a lower level of severity. In other words, they were less impaired for longer when they were on this therapy compared with those on placebo. And you save about 4.5 to 7.5 months over the time period of the study if you're on this drug. And indeed, just under half of patients on donanemab had no change at all in their CDR sum of boxes at 1 year, indicating no disease progression, compared with 29% on placebo. And so that is something that I share with my patients and that they find clinically meaningful. So by week 76, about 2/3 had met the stopping criteria and had cleared their amyloid. Again, both of these drugs are very good at clearing amyloid. There's very little debate about that. And interestingly, on volumetric MRI, there was actually a greater decrease in whole brain volume. In other words, more atrophy in those who were on donanemab. And I think as a field, we're trying to figure out, is that due to amyloid clearance or some other reason? I think stay tuned. And so let's compare the two, lecanemab and donanemab. So in terms of adverse events, deaths related to treatment on donanemab, there were 3 during the study, 0 during the actual phase 3 trial, but there have been subsequent deaths in the open label extension. The risk of ARIA-E with donanemab was about 24%, and about a quarter were symptomatic, versus 13% with lecanemab. So the rate was lower with lecanemab. The rates of those that were symptomatic was fairly comparable. Donanemab, I'll talk about kind of a change in the dosing schedule that's been proposed that may result in lower ARIA-E rates shortly. ARIA-H was fairly comparable between the two. And so any ARIA, about 37% with donanemab, about a fifth with lecanemab. Intracerebral hemorrhage was present, but rare in both and fairly comparable. And infusion-related reactions were much lower in the donanemab study versus the lecanemab study overall. So I did just want to share that there's a new modified titration schedule that's been proposed and published for donanemab. And keep in mind that the numbers are much smaller than in the study compared with the phase 3 trial, and furthermore that they were just looking at ARIA through 24 weeks rather than 76 weeks. But nonetheless, they were able to dramatically lower the rates of ARIA-E. So overall ARIA-E in the modified titration group was about 14%, so fairly comparable to the lecanemab study. And ARIA-H was about 20%, so similar to the original phase 3 study. But they were able to reduce the rates of ARIA-E substantially with this modified dosing schedule, and we are using this modified dosing schedule at Stanford. So with that, I'd like to thank you for your time, and that concludes this episode.